I'm delighted to be part of this conversation, and I really think we have time for it to be a conversation. The current enthusiasm at many levels for the concept of precision comes from the recognition that and excitement, appropriate excitement, generated by the fact that for a few cancers, this is really making a big difference. And I think those of us watching this or leading projects related to this recognize that learning how to intelligently use genomic information in healthcare is going to change some things a lot. So I want you to know something which the people in this room are well aware of, which is the incredible ways in which our healthcare system isn't working very well. And as shown, for example, by this study on healthcare quality, access, efficiency, and equity. So the kind of long-term concerns that are well represented in this room are also concerns that are very much shared by those of us who have the responsibility for the NIH launch of this. And it is recognized that we need to develop research processes that capture a larger segment of our society than we have historically always brought into clinical research, and that we have to begin to address and think about the incredible health disparities that follow socioeconomic status in our society. So I see this as a challenge to make care more precise, but that precision means incorporating understanding of the variables that impact on that person's health, including the community factors, including the impact of lack of resources in self-care. So I do find that the enthusiasm for genomic markers is sometimes blunting a message that there's a lot of ways in which use of diagnostics, approaches to healthcare need to be better individualized, and it isn't only genomics. Just a little preamble, because I think that's extremely important. So the enthusiasm for this did start with a bill which President Obama introduced into the Senate more than almost 10 years ago. So President Obama is an incredible champion for change in our healthcare system. He is championing the idea of building a large million-person cohort of engaged people. That's the part of the project that I am temporarily, while we search for a permanent director, in charge of. But Obama is also leading efforts to improve people's access to their own health information and to increase the accessibility of health information with the participants' say-so for clinical research. And that's another part of ways in which the political climate is facilitating some very important changes that all sometimes are put under the umbrella of what is precision medicine. This is the goal to enable a new era of medicine through research, technology, and policies that empower patients, researchers, and providers to work toward development of more individualized therapies. That was written and part of by the White House, and it's now a little more than a year old, that mission, and we're working hard to implement it. But I wanted to begin with a kind of personal riff on why I, in my gut, recognize that the imperfections that come into the delivery of health care because we don't have more precise answers. And I'm going to use an example that, for any woman my age, is one where you have a real sense of personal impact, and that is breast cancer. I last summer went to my 50th high school reunion. I went to a small school. There were 20 of us sitting around the table, and 9 people called themselves breast cancer survivors. And that's not totally atypical of a sort of 70-year-old women. But I've been following the work of Gilbert Welsh very closely, and had just finished reading and pulling together some of the data on overdiagnosis of breast cancer. I was very familiar with this controversies that have followed U.S. Preventive Task Force and other recommendations. And although my official countenance there was just sympathetic, I couldn't help but think how many of these people who've had the most scary event of their lives were, in fact, not at risk of death of breast cancer. And I think people in this room will know this kind of data. This tells us that since in the 80s, when we began screening for breast cancer, we had this, that's the middle graph, the blue line, shows us we've had this huge uptick in the number of cases of breast cancer, but virtually no comparable fall in the number of late-stage cases. We've had some improvement in therapeutics that have improved outcomes for the late-stage people, and a little impact on breast cancer death rates, and those are all really important. But if these early-stage breast cancers were all going on to late-stage, the red line should have fallen just as much. So that's a startling illustration of the fact that when we don't know who and how to do diagnostic screening wisely, we end up creating enormous health burdens for people. Now, I don't think anybody did anything wrong here. It's just we didn't have the right answers. And I hope that 5 to 10 years from now, we will have enough understanding, perhaps at a molecular level, but perhaps also incorporating things like simply family history or body mass or other variables to be able to better understand which of those lumps really deserve treatment as a life-threatening issue. And there's already a fair amount of attention to this. I think there's recognition that the pathology at DIC is probably much benigner than had been thought. But it is a reminder, or the women sitting around the room in my high school reunion, that when we don't have good evidence-based answers for diagnostic screening, we are doing not only good but also harm. And I'm not going to give you an opinion on where the balance is. I'm a bit of a therapeutic nihilist in lots of areas, but I'm not sure that I could have reassured any one of those women individually, because we just don't have the data. But this is a part of how I explain to you my passion for precision medicine. So here's a quote from the Blyer and Walsh paper. Unfortunately, the number of women in the United States who present with distance disease, only 25% of whom survive for 5 years, appears to have not to have been affected by screening. We estimate that breast cancer was overdiagnosed, i.e. tumors were detected that would never have led to clinical symptoms in 1.3 million U.S. women in the past 30 years. This is Blyer and Welsh, and I think this is considered to be reasonable estimates. So another way to think about the need for precision is to think how many of the drugs we use have very high number needed to treat. So this is one estimate of the number needed to treat and the number needed to harm. So statins for prevention of heart attacks Well, at least one estimate would say that if to prevent a heart attack, we treat 100 people to prevent one heart attack, but there's some toxicity. And this is an interesting resource, the number needed to treat group. I'm not an expert enough to tell you that these numbers are hard or should be written in stone, but I think the methodology's been reasonably critically looked at. So while we think of precision medicine as important for its promise of new therapies, it is also important for balancing benefits and harm. And what the cohort program that I'm leading, I think of as one of the most important ways it will change medicine and clinical research is scale. I've been leading clinical studies at NIH for almost 2 decades. And at the end of a study that we had worked hard to make happen and managed to get 2,000 people in and enrolled and through the placebo control and the active control, and 5 years later we finally have an answer. And then there's some subgroups, and the statisticians tell us you haven't got any power to say anything about subgroups. And this is always extremely painful, and I'm sure a number of you have experienced this issue. So I have come to feel that much of what we're doing in clinical research is grossly underpowered, that we need to be doing studies in which we bring rigor to the methodology, but at the same time have more people in the studies. Now, Lynn has been one of the stars in the Healthcare System Collaboratory Project that I've had the honor of leading for the last 5 or 6 years. And what that program is largely doing are larger scale studies that can be larger scale because they are embedded in healthcare systems. They capture some of the information for either enrollment or outcome measures from real clinical data as opposed to all site-generated research process-generated data. And we've tried collectively to make these studies as simple to implement as possible. And through that project, we are funding approximately 10 studies right now. They vary in size from a few thousand to 30,000 people. And this really activates my colleagues. They are costing less than $500,000 direct costs per year. And that's close to a factor of 10 to what the NIH typically has to pay for studies of this size. Now, I think the potential of this way of doing clinical research, we're only beginning to scratch the surface. But the Precision Medicine Initiative, in addition to generating an infrastructure for doing genomic tests, will be, we hope, 1 million people who are committed to clinical research who are interested in participating. And it will be strengthened systems in major healthcare providing organizations for utilization of real-world clinical data for the research process. The geneticists were the first to squawk that the size of their studies wasn't adequate. People doing studies like GWAS said, gee, you've found me 10,000 people, that's way not enough. NIH, you've got to figure out how to get us 100,000 people. And that was always pretty costly. But the concept behind the million cohort volunteer is a careful building process to get a core set of data and information, but mostly the emphasis is on getting people engaged. And that's why I'm delighted we've managed to hire the person who's next on the program, who will be our director of participant engagement. She was one of the co-chairs of the advisory committee that developed the plans for this cohort, and she's thought a lot about how to really engage people in a way that keeps them interested. Now, we don't have the answers yet, but we hope over the next 6 months and a year to begin building the blocks that will make that happen, and then to build that to a larger and larger scale. Our goal is to have 1 million people signed up by 2019. If we had 1 million people, here's some data. This data actually comes from largely from the BioView Vanderbilt network. How many cases might we have for some of these common diseases? Now, the numbers, when you actually crunch them, of course, it depends a lot on the actual population, but 1 million's a very big number. And as a consequence, if you look at how many cases you'll have of important conditions, you end up with big numbers, bigger numbers than most of our existing trials. So here's some of the whys. Many diseases lack effective prevention strategies, diagnostics, or treatments. Options fail to consider key differences among individuals. Genes, yes, but also lifestyle, environment, personal preferences. So that's one part of the why, is that whole therapeutic drive. But another is that we really are trying to help give more momentum to a change in clinical research, which has certainly also received substantial momentum from the activities of PCORI, but is to make participants more at the center of the clinical research process. And a part of this is a notion that we also have to learn how, with appropriate provisos about the strength of evidence, feeding findings back to the people who are participating in ways that help maintain their engagement. But this is more than the genome, although the genome's an important part. In the working group that developed the core principles for this program, we came up with these broad principles. Participation open to anyone interested. Participants are partners in all phases. Participants will have access to study information, data about themselves. The data will be put in a place that's broadly accessible to any appropriate person, that there will be careful adherence to privacy and security rules, and that this should be a catalyst for changing the whole research process. So 1 million or more volunteers, broadly reflecting the diversity of the U.S., recruitment strategies that ensure we have a strong component of underrepresented groups. It's a longitudinal cohort, so we hope to convince people to be in it for the long haul. Everybody who signs up will be asked about their willingness to share their electronic health record data, to provide a blood and urine sample, complete a baseline simple physical exam, and a number of modules of survey information. We will be utilizing 2 methods of recruitment, direct volunteers. We have just begun funded awardee Vanderbilt with partnership with Google or Verily to develop a participant-provided information interface and to start learning some of the variables that determine people's willingness and interest in signing up. We have received applications for healthcare provider organizations to be recruitment sites. We have a very robust response. We're very pleased with that. We hope to make those awards by the middle or end of June. And we're also working with HRSA on a very small scale pilot with a few FQHCs to learn how to work in environments where healthcare is provided to people with very little financial resources. large and diverse, but we are not attempting a representative sample. There's a lot of reasons for this. It's been intensely discussed, but it is partly cost and partly the arguments that one would have to have with each iteration as to what representative of what. But it is mostly that that to achieve scale, which is our primary emphasis, one will inevitably have skews from representativeness. We hope to know enough about the cohort to be able to compare it to reference data sets like NHIS and NHANES and potentially choose subsamples that would be with strategies that would make them mimic a representative sample. But 1 million people is a very large number, and it really will permit us to have much more well-powered subsets. This is a list we've been using in talking about the scientific opportunities. This is the type of data that we are expecting to collect in the first round. A very important emphasis on participant-provided information as the core data set. A very simple physical exam, probably pulse, blood pressure, height, weight, and not much more. The structured clinical data will be diagnostic codes, medications, and select lab values. We will probably not in the first phase be collecting vital signs or encounter records, since we're getting vital signs directly. The first biospecimen will be a blood sample, and because I'm a kidney doctor, we're adding a urine sample. And there will be some experiments in the first year with passively collected data from sensor devices on a pilot kind of basis. Data comes in from all these sites, data flows out back to the volunteers, but also to a broad research community. And one of the conditions of using the data and using samples will be that the data from all studies needs to come back. We hope that that's basically the major limitation is we have to impose is you promise to tell us everything you learn, regardless of whether you think it's publishable or not. So that's my comments.